Hello, everyone. As you mentioned, my name is Dr. Chantalle Grant. I'm from the University of Alberta in Edmonton, Canada. And we'll be discussing a propensity-matched analysis of concurrent cholecystectomy with bariatric surgery. I have no disclosures. I'm supposed to sit here for 7 seconds and let you stare at that, but nothing to let you know about. Essentially, bariatric surgery is hugely important in the world today because, as we all know, obesity is an enormous problem. Over 650 million people worldwide struggle with obesity, and that's made bariatric surgery one of the most common elective procedures performed today. Among those, the most commonly performed are the laparoscopic Roux-en-Y gastric bypass and the sleeve gastrectomy. Going along with this, obesity is a major risk factor for gallbladder disease, as is rapid weight loss, so bariatric surgery patients are at extremely increased risk for gallbladder disease. An extra concern for them is the risk of choledocholithiasis in these patients due to the altered anatomy in bypass patients. Some of the rates in cholelithiasis alone, just gallstones alone, some estimates have as high as 52.8% of patients after bariatric surgery, and cholecystectomy rates have varied between 7 and 35% following bariatric surgery. There's a number of different options for managing the gallbladder in bariatric surgery. The first is the one we're going to focus on today, and that's performing a routine concurrent laparoscopic cholecystectomy, or in every single bariatric surgery patient, taking out their gallbladder to prevent these risks of having complications from gallbladder disease down the road. Other options that have been proposed is risk stratifying patients using an intraoperative ultrasound, whereas if the patient has gallstones, you proceed with the cholecystectomy with the bariatric surgery. And if the patient does not have gallstones, you perform a bariatric surgery alone. Others have proposed performing a concurrent laparoscopic cholecystectomy only if symptomatic, so essentially the same considerations that you would use for any other patient. And still others have said you should consider giving ursodeoxycholic acid treatment afterwards, but this is somewhat limited by cost and patient tolerance and compliance with medications. The routine concurrent laparoscopic cholecystectomy is currently surrounded by quite a bit of controversy. There's a number of studies suggesting it is safe, but there's a number of studies that also suggest there might be a longer length of stay, higher complication rates, and even higher mortality. A recently published review in 2019 said that there may be a small increased risk of anastomotic leak and stricture, but overall the small number and poor quality of data made it hard to say. So for our study, we accessed the MBSAQIP database, which collects data from most of the bariatric surgery centers across the US and Canada and undergoes regular audits. We included all patients with laparoscopic Roux-en-Y gastric bypass or sleeve gastrectomy and excluded patients who had a revisional or an emergency surgery, excluded patients with a BMI less than 35 or missing BMI data. We were able to collect a number of variables. On the left-hand side of your screen, you'll see the patient variables ranging from age, sex, race, BMI, comorbidities, past medical history, preoperative functional status, and ASA status. We used these scores together to create our assigned propensity score. Our outcome variables, our primary outcome variable was 30-day overall major complications, which you can see here included all of the following. Our secondary outcome variables were operative time, length of stay, and 30-day mortality. I just want to explain a little bit about how propensity scoring works. Essentially what it's able to do is it merges all confounders into a single vector, and it assigns each subject a propensity score or a single number that adjusts for characteristics like their age and their comorbidities, which we showed on the previous slide. You can then take your exposed subjects, the people who had the cholecystectomy with their bariatric surgery, and compare them directly to their nearest match with a score of the person who has the closest propensity score without having had the concurrent cholecystectomy. This is called a one-to-one neighbor matching, which we performed without replacement for propensity scores within 0.2 standard deviations. If we had not performed a propensity score, these two groups do not have similar characteristics and are not appropriate to compare. But with propensity scoring, we can demonstrate that they are statistically similar, and we can eliminate approximately 99% of confounding due to our measured confounders, and then perform our univariate analysis. We collected data for over 265,000 patients, the majority of whom, 70%, had a sleeve gastrectomy, and about 28.5% had a gastric bypass. Only 2.2% of these total also underwent a cholecystectomy with their bariatric surgery, and from those, we were able to use most of them. 5,894 matched pairs were created. Our primary outcome was 30-day major complications. And we found that in the exposed concurrent cholecystectomy group, we did have a statistically significant difference with higher complications in the concurrent cholecystectomy compared to those who did not have a cholecystectomy, at a rate of 4.6% to 3.7%. This was largely due to higher rates of cardiac events and higher rates of acute renal failure. We found similar rates of bleed, leak, reoperation, and readmission, however. In terms of our secondary outcomes, there was no significant difference in mortality, and perhaps not surprisingly, there was a longer operating time in the concurrent laparoscopic cholecystectomy group at about 118 minutes compared to 90 minutes. So essentially, there has been a recently published study on a similar topic that used smaller numbers of patient data, just a 1 year's worth of patient data, and we had a larger patient group to choose from. They did not find a significant difference, but in our study, which is a larger cohort, we were able to show a significant increase in 30-day morbidity with concurrent laparoscopic cholecystectomy. This may lead to considerations of not performing a concurrent laparoscopic cholecystectomy at the same time as bariatric surgery, but at the very least is worth considering having a discussion with your patients about the fact that there could be increased risk associated with performing it at the same time in someone who may not ever need their gallbladder removed at all, and so something to consider. Thank you very much.